Hey guys, welcome to my 10. So basically in this video we'll be discussing about the tumors of the middle ear. Tumors of middle ear. Okay. So basically we do have two types of tumors. We have a primary tumors followed by the secondary tumors. So in the primary tumors again we have the benign and the malignant. Benign and malignant. In the benign we have something called as the glomus tumor. So today's topic of discussion will be about glomus tumor. So what is glomus tumor? It's a benign tumor which is a primary tumor of the middle ear. Then what do we have in the malignant? In the malignant we do have carcinomas as well as sarcomas. In the secondary tumors, what we have? Secondary, it might arise from the adjacent areas, which might be from the nasopharynx or external meatus as well, or it may be metastatic from the lungs, bones, etc. So tumors of the middle ear, we have the primary tumors and the secondary tumors, and benign and the malignant. In the benign we have glomus tumor. In the malignant we have carcinoma as well as sarcomas. In the secondary tumors we have the structures arising from the adjacent structures which are from the nasopharynx as well as the external meatus. Then we have some other the metastatic from the bones as well as lungs. So today's topic of discussion is the glomus tumor. So what is glomus tumor? Glomus tumor is a benign neoplasm of the middle ear. Benign neoplasm of the middle ear. So this is actually made up of the paraganglionic cells which are derived from the neural crest cells. Derived from neural crest cells. So glomus tumor is a benign neoplasm of the middle ear which is made up of the paraganglionic cells derived from the neural crest cells. Okay. So what are the different types we have? We have glomus jugulare and glomus tympanicum. Okay, these are the two types of glomus tumor, the glomus jugulare as well as the glomus tympanicum. Glomus jugulare, it arises from the dome of the jugular bulb. And this leads to the compression of which nerve? The 9th and the 12th nerve. Compression of the 9th and the 12th cranial nerves. Okay, it arises from the dome of the jugular bulb. Sometimes it may also compress the jugular vein as well. Then we have something called as the glomus tympanicum, and this arises from the promontory of the middle ear. And it causes oral symptoms associated with maybe hearing loss, or sometimes there might be facial paralysis as well. So basically these are the two types of the glomus tumors, glomus jugulare as well as the glomus tympanicum. Glomus jugulare arises from the dome of the jugular bulb. Sometimes it may also compress the 9th and the 12th cranial nerves, which leads to the particular symptoms, as well as there might be compression of the jugular vein as well. In the glomus tympanicum, it arises from the promontory of the middle ear, and it causes general oral symptoms. There might be a little bit hearing loss as well as a facial paralysis. So what about the features of this tumor? This tumor is extremely vascular. So this tumor is extremely vascular. It is benign and it is non-encapsulated. Okay, so this actually in the histopathology it appears as masses and sheets of epithelial cells. Which have a coarse granular cytoplasm. So this generally occurs in the middle age group. That is 40 to 50 years, and the females are more affected than the males with the ratio of 5:1. So these are the basic things that you need to know about glomus tumor. The next basic understanding that you need to have is how does the spread of glomus tumor occurs. So now we look at the spread of glomus tumor. Okay, so the first thing, what happens, the tumor may initially it fills the medullary cavity and later it may perforate through the tympanic membrane, presenting as a vascular polyp in the external auditory canal. So what happens, it initially builds up in the middle ear, following it leads to perforation of tympanic membrane and may present as polyp in the external auditory canal. Okay, so this is how the first thing is, it might build up in the middle ear, later leading to perforation of the tympanic membrane and presenting as a vascular polyp in the external auditory canal. And whatever the second thing, it may invade through the labyrinth or the petrous pyramid as well as the mastoid. It may, what happens, it may invade the labyrinth and it may also invade the petrous pyramid it may also invade through the mastoid. Okay, then what else it can do, it may invade through the jugular foramen, that is the base of the skull, causing the 9th and the 12th cranial palsies. As I just told you, the another variety, that is the glomus jugulare, it may invade through the jugular foramen leading to the 9th and 12th cranial palsies. Okay, and what else, it might also spread through the eustachian tube present in the nasopharynx. Sometimes it may travel through the eustachian tube and present into the nasopharynx. Okay, then it might also spread intracranially to the posterior as well as the middle cranial fossa. Posterior spread into middle as well as the posterior cranial fossa. Okay, then finally there might be a metastatic spread to the lungs as well as the bones. Through the lungs as well as the bones, it might spread metastatically. So these are all the things that you need to remember regarding the spread of the glomus tumor. Okay, it might build up in the medullary cavity, leading to perforation of the tympanic membrane and presenting as a vascular polyp in the external auditory canal. It might also invade the labyrinth as well as the petrous pyramid as well as the mastoid as well. Then there might be invasion through the jugular foramen, compressing the 9th and the 12th cranials, leading to the cranial palsies. It might go through the eustachian tube into the nasopharynx, presenting in the nasopharynx. It might also spread posteriorly into the middle and the posterior cranial fossa intracranially, or there might be a metastatic spread in the lungs and the bones. Okay, so this is about the spread of the glomus tumor. Now we'll look at the clinical features of the glomus tumor. So what clinical features do you have? In around 90% of the cases, the symptoms pertain only to the ear. That's what you need to know. In 90% of the cases, the symptoms are pertinent only to the ear. Now there will be different circumstances the patient may present when it is intratympanic and when it presents as a polyp, or there might be associated cranial palsies. So firstly we'll look at when the tumor is intratympanic. Okay, what happens when the tumor is intratympanic? The first earliest symptom that the patient presents is hearing loss along with the tinnitus. The first thing that the patient presents with is the hearing loss as well as the tinnitus, and this might even mimic the Meniere's disease as well. So how is the hearing loss? The hearing loss is generally of conductive type there is conductive hearing loss, and it will slowly progress. And how is tinnitus? Tinnitus is actually pulsatile. Tinnitus is pulsatile, you can say. Okay, tinnitus is pulsatile. So on examination through the otoscopy, what you will find? You will find two signs. Okay, if you are examining through the otoscopy, two signs. One is the rising sun appearance, the other one is the pulsation sign. Okay, we have two signs, that is the rising sun appearance and the pulsation sign. In the rising sun appearance, through the intact tympanic membrane, we can see a reddish reflex when the tumor is arising from the floor. And if you are seeing through the tympanic membrane, you'll see a reddish appearance below. Okay, so this looks like a rising sun. And what about the pulsation sign? Pulsation sign is positive because when the ear canal pressure is raised with the seagull speculum, the tumor pulsates vigorously. When the ear external auditory canal pressure is increased using the seagull speculum, the tumor actually pulsates. The tumor pulsates vigorously. So this is the pulsation sign. Now next we'll look at what happens when the tumor presents as a polyp. Okay, the second one, that is the tumor presenting as a polyp. So what happens in this condition? The patient also experiences hearing loss and tinnitus, but the patient often gives a history of profuse bleeding. So since it's presenting as a polyp, there might be history of profuse bleeding. It might be a trauma that he might be indicated, or there might be again spontaneous. Okay, so along with the history of hearing loss and tinnitus, the patient complains of profuse bleeding from the ear spontaneously, and this bleeding is also associated with dizziness and vertigo. Sometimes this bleeding is associated with dizziness as well as vertigo. Okay, the patient also presents with dizziness and vertigo along with facial paralysis as well. Okay, this is what you need to remember. The third thing we have is the cranial nerve pulses. So what happens in the cranial nerve pulses? We'll look at it now. Cranial nerve pulses. In the cranial nerve pulses, this is generally a late feature of after several years of the oral symptoms. It presents as a late feature. Okay, whenever there is 9th and 12th cranial nerve compression, there is 9th 12th cranial nerve compression. What happens? The patient presents with dysphagia and hoarseness. The patient also has dysphagia. There is hoarseness of the voice due to unilateral paralysis of the vocal cord, and the patient also has weakness of the trapezius and the sternocleidomastoid muscles. Weakness of trapezius as well as the sternocleidomastoid muscles. So this is what happens. Sometimes you can also hear an audible bruit. Sometimes you can hear an audible bruit over the mastoid due to the pulsation of the GLOMUS tumor. So how do you diagnose the condition? So moving on to the diagnosis part. In the diagnosis part, first what we'll do a CT scan of the head. CT scan of the head. It might also be combined with an MRI to indicate the tumor. Then we can also do a 4-vessel angiography. Okay, 4-vessel angiography along with the brain perfusion and flow studies. Following, we can also use embolization. Okay, then what are the treatment modality for the GLOMUS tumor? Okay, in the treatment modality we can do either surgical removal, we can remove surgically, we can do radiation therapy, or else we can do embolization. Then we can also do the combination of all the both techniques, combination of all the above, that is these conditions. Okay, so this is about the treatment modality of the glomus tumor. So thank you guys, thank you for watching video till the end. Make sure to subscribe and hit the like button, and I'll see you again. Bye.